I'm Dr. Nancy Kuntz, a child neurologist at Ann and Robert H. Lurie Children's Hospital of Chicago, Northwestern University.
And I'm Sam McKenzie, a physician scientist, child neurologist, and neuromuscular specialist at the University of Rochester.
And we're here today with this microlearning series to discuss some of the side effects of treatments for some of the most recently introduced drugs and therapies for Duchenne muscular dystrophy. Sam, I guess we should first start talking about our experience with givinostat, which has been introduced after trials in Europe that show significant improvement and additional benefit to other therapies in prolonging ambulation and function in Duchenne muscular dystrophy. So it's been very promising. I think the introduction of this medication can be complicated for the child because there are a number of things that need to be monitored with dose adjustments until you get it quite right, although most children tolerate it. What's been your experience?
Well, I think it's an interesting medication, right? So this is one that doesn't work on the DMD gene per se. It's a histone deacetylase or HDAC inhibitor. So it really is targeting gene transcription throughout the genome to reduce inflammation and the loss of muscle. So certainly when we think about those potential off-target effects, we have to think about side effects very carefully. One thing that we've seen, and this was reported in the clinical trials, was thrombocytopenia or a decrease in platelet counts. Sometimes that doesn't require us to stop the medication, but it can inform a reduced dose. So that's one of the more common ones that we've seen at our center.
And we've also seen elevation of triglycerides. Again, usually not something that requires stopping the medication, but something that gives us the opportunity to review basic nutrition and guidance in that regard to the children. And that, in my experience, most of them, just with some adjustments to their diet, don't even need adjustment in the dose, but there have been reported some children who require a small dose adjustment to get their triglycerides under control.
Other systems that we think about with givinostat include the heart and the liver. On the cardiac side, we know that givinostat can cause a prolongation of the QTc interval. So I think it's really important to obtain a baseline EKG in our patients, and then also think about other medications that they may be taking that can also cause QT prolongation. On the liver side, we know that givinostat is eliminated through the liver, and so if children have some other cause of hepatic impairment at baseline, we think that this can increase the exposure to the drug, which can then exacerbate other side effects.
Oh. Well, givinostat is one of the newest therapies that's being introduced in a widespread fashion, but one of the other therapies that many of us monitor adverse events from are the exon skipping agents. There have been a handful of different exon skipping agents for a number of years, many of them now commercially available. Again, these are directed toward the specific mutation, so not all mutations are amenable to an exon skipping agent, but that fraction of the total number of boys with DMD who are amenable to exon skipping have been for some time receiving weekly IV infusions. And so the side effects not only include reaction to the medication, but also the need for repeated IV access. So most of my boys have central venous access ports that they have had to have placed in order to have this therapy done. But with that in place, they can usually do this via home health and with less disruption of their life.
Yeah, agreed. I think we try to avoid a central access until we need it, right? So most patients can go several years, but at some point, if it becomes hard to get peripheral access and there's been benefit to the treatment, those are certainly conversations that we have as well.
There is some potential with some of the newer agents being introduced in clinical trial for less frequent dosing, so perhaps once every 4 weeks. But right now, the overwhelming majority of boys are on once every week therapy. And these are the ones that we're continuing to monitor, not just for the IV access issues, but also for things like urinary protein excretion, monitoring their kidney function.
Yes, and I think a lot of those monitoring recommendations are really born out of preclinical studies on exon skipping agents that showed that there was actual renal damage. We don't have a lot of human evidence that I'm aware of showing that, but it's certainly something we check in the form of cystatin C, monthly urine protein, and if we do see that the protein levels in the urine are going up, we will have conversations with the patient's family, and sometimes our nephrology colleagues about whether we should think about a dose adjustment or a change off of the medication.
Right. I agree. Most of the boys who've had long-term therapy with the exon skipping agents, at least the first generation, have done very well, despite the cautionary preclinical studies. And I think we'll just have to wait and see how the newer agents do over time. I'm looking forward to doing that, although we'll have to learn a new set of possible side effects because some of them do appear to have more electrolyte and protein leak in the urines than some of the first generation.